Hi, everyone. It's a pleasure to be with you. And so this morning, we're going to go through a little bit of introductory and more than introductory stuff about asthma. First off, what is asthma? And I think this is important, understanding how we'll frame the talk and what we'll hope to understand from the talk. So it's an interaction of genes, who your parents are, what you inherited, your tendency to asthma and allergy, and to your environment, where you work, what air you're breathing. There are two key features for asthma. One is its reversibility, and the other is its reactivity. And we'll talk about that a little bit in a moment. The underlying triggers are inflammatory. It's an inflammatory process, whether it's based on allergy, infection, or irritant response. And in some patients, especially those who've had it for a very long time, and they haven't possibly had adequate therapy, there's airway remodeling in some, so it begins to pattern along towards COPD. All asthma is not the same, and this is going to be a very important feature of what we're going to talk about this afternoon. Asthma is a heterogeneous disease. Important features that separate out the different patterns. The number one that seems to be very, very helpful and very simple is age of onset of disease. The progression, what's the pattern of progression? Is it something that starts with a bang, or does it come on slowly? And then what are the inflammatory pathways involved, which is going to be very important in order to understand the treatment. So what we're going to treat some asthmatic with certain approach, and other asthmatics with a somewhat different approach. So understanding the inflammatory pathways in order to then understand what the treatment should be. So this is the basic slide of the whole talk. And there's a lot here, so let's take our time and look at it, because it really points up all the new components of understanding asthma. So on the x-axis, we have time. When does the asthma begin? Does it begin in childhood, or does it begin in adulthood? So that's, as you proceed this way across this picture, this is childhood onset down here, this is adult onset over here. Severity is on this axis. So the higher up you are on this graph, the more severe that your disease is. And then we have this sort of strange division of etiologies. We have Th2 asthma, and then we have non-Th2 asthma. So why would you have something called non-Th2? It seems like a very silly way to describe something, but that's the basic breakdown of the etiologies of asthma. So what is Th2? Th2 is the asthma that's driven by certain cytokines that are involved in allergy, whether it's driving your IgE or your eosinophils. That's a Th2 kind of asthma. But there are those patients who have asthma that it's not driven by eosinophils and IgE, and we call it non-Th2. And this is more driven by the cellular immunity and the immunoglobulin immunity, not the allergic immunity. In the non-H2, we do not understand the etiology as well as we do for the Th2. We don't have good approach to treatment, but it's very important in our mind that we separate out these two, because non-Th2, or things that are not related to IgE or eosinophils, are not going to be so responsive to steroids. And since steroids are the basic tool that we use, we want to make sure that we're not giving excesses of steroids to patients who are on this side of the picture. And we're going to go through this in a little bit more detail, but basically you have your childhood onset, which includes the patients who have allergic asthma. And by that I mean it's IgE mediated. They have a lot of atopy, they have urticaria, they have lots of allergies, they may have anaphylaxis, and this is your childhood onset classic asthma. And it can be mild or it can be severe. But these are the patients who especially we give Xolair to. We give them all our regular inhalers, but we also, this is the kind of patient who would benefit from Xolair. But then as we get to adult onset asthma, we're going to be having more of the eosinophilic phenotype that may have some IgE, but not as much as these guys do. So you have your late onset eosinophilic asthma, you have your very late onset eosinophilic asthma. And so these tend to be severe right from the get-go. You develop this after an infection very often, and you wind up with severe adult onset asthma. Further to the right here, we have obesity-associated asthma. And so some of that is mediated through leptin, which is a pro-inflammatory cytokine, and it certainly isn't something you want to be treating with steroids. There's also mechanical components. There's GERD that's relevant in obesity. So obesity-associated asthma, we really want to be talking to our patient of how we're going to handle the obesity. Many of these patients will be on inhaled corticosteroid, but we have to be very cautious, especially if we're giving systemic steroids, that this may not be a steroid responsive asthma. And there's nothing to say that this patient didn't become obese, but keep in mind that some people have just obesity-associated asthma. Then we have neutrophilic asthma, and neutrophils don't get better with steroids. Eosinophils get better with steroids. And this may be triggered by smoking, is one of the triggers that may be present. And then we have even patients who have very little cellularity if you were to biopsy their lung. Smooth muscle hypertrophy, little inflammation. And again, we're not going to be giving these patients steroids because they don't even have very much inflammation. And we don't understand this part of the disease that well. It may be that they used to have eosinophilic asthma and now it's all burnt out and you just have bronchiolitis. We don't know. But we're going to talk through in our talk today, we're going to look at these and try to develop a plan for how we would approach them. So first we start with history. So the history, reactive and reversible. So I always say the same thing. You have somebody, they clean the house, they sweep the floor, the dust gets in their nose, they start to wheeze, they take their albuterol, and they get better. That's reactive and reversible. That is asthma. You do not need any blood test, any PFT, anything to diagnose that. You know it just from the history. But not everybody has such a classic presentation. But you want to get that presentation so that the patient can be reassured that right away you're understanding what's happening with them. So clearly age of onset is going to be an important part of our history. Symptoms are going to be important. Do they have wheezing or do they have more of a coughing manifestation? Do they bring up plugs? Plugs are really important for the person who's very severe asthma, especially if they have ABPA and they have allergic bronchopulmonary aspergillosis, which really brings up hard brown plugs. Is it episodic? Is it seasonal? Is it more nocturnal? We're going to approach these a little bit differently. How much sinus disease is there? Are there nasal polyps? Are they aspirin sensitive? Is this a post-infectious presentation or is it mainly allergic? Do they get anaphylaxis? Do they have a strong allergic history? Are they part of what we call the atopic march? In other words, pardon me, do they have an underlying physiology that makes them prone to asthma with such things as asthma, allergic rhinitis, allergic conjunctivitis? Do they have panic? Very important component of talking to a person with asthma, because they all have panic because it's panicky to get short of breath. But some people have more panic than others. And we want to understand in a non-judgmental way or a non-dismissive way how to help their panic because we don't want to just treat the asthma. If panic is part of it, we want to help them have tools to handle the panic, which can be very, very, very hard on the patient. We want to ask them about their triggers. Is cold air a trigger? Is exercise a trigger? Is there something in their home or in their workplace that's triggering their asthma? You always want to ask in your pulmonary history about the air they breathe. Is it, whether it's at home or at work, what kind of air are they exposed to? Are there chemical irritants? Uncontrolled exposures, so exposures that they can't avoid. They have animals at home. They work in a place that's dusty. These kind of things are very important to get to the bottom of so you can understand why our patient may not be getting better. Is there a family history? So that strengthens your suspicion that someone who is short of breath and episodically short of breath, if they have family history of asthma, maybe it is asthma. And then do they have sleep apnea? Do they have reflux? Are they smoking? And again, do they have anxiety? So, as you know, one of the main things of asthma is, are they taking their medicines? Do they know how to take their medicine? So you want to ask them, go over what medicines they should be taking, how often they should be taking them. But part of it is definitely about how they do it. So we know that in asthma, 50% of our patients have poor adherence to their medicines, 50%. So that means the patient who really looks like their act together, half the time they don't, because they don't know them, or they don't know how to do them, or they don't want to do them. So if you're going to be making adjustments to their medication, it becomes guesswork because you don't know how much medication they were actually getting in their system. So this is an important conversation to have with the patient. How much do you really think? Because we want to be able to adjust your medicines according to what you're actually getting in your system. And then inhaler technique accounts for between 50 to 80% of patients who are thought to have severe asthma. They don't know how to do their inhalers. And I know that Tony last week went over inhaler technique with you in his COPD talk, but I'd like to put my own educational pearls in there. And these are some thoughts that I find help with the patients. It only works where it lands. So it's quite reasonable for a person who is taking their medicine and ordinarily swallow their medicine, that if they get it inside their body, they think they took their medicine. It's perfectly reasonable. So we have to tell them that inhalers only work when it gets in your lungs. That means that you need to pull it in through your mouth. You don't want to be pulling it through your nose, the breath through your nose. You want to pull it in through breath through your mouth, so that in order to pull it with your breath into your lungs. The other thing, they'd have to understand that their lungs are big. So I'm always going, hey, your lungs go from here to all the way down here, to give people a sense of how big the volume that they have to distribute the medicine in. Your lungs are big, so you have to pull it in really hard in order to get it to go all the ways down to the bottom of your lungs. But then once it gets in, it must settle. If you breathe out, you have to hold it for 10 seconds. If you breathe out, the medicine comes right out. So just like anything that you're trying to deposit in there, it has to get time to get in and to sit there. So it's stuck on the mucous membranes. It's not just floating around and then gets breathed right out. If you cough when you do your pump, it comes right out. So you should take it again. You should repeat it so that you're sure that your medicine got into your body all the way down to the bottom of your lungs and got settled in there. So measuring adherence is another issue. So we ask the patient how often they take it. How often do you take it on the worst week, when you're the busiest, when you're the most stressed? How often is so? It gives us an idea of how to modify dosing. There are dose counters on the inhalers, but most patients bring a new inhaler with them when they come to clinic. So the dose counters are good. They're helpful, but they're not always helpful. Prescription rate refills are visible in Epic. So you can see how often your patient is filling their medicine. But if you're not able to do that, a phone call to the pharmacy is often so valuable, because here you are thinking that they need to go on dupilumab, but they haven't filled their Symbicort in 2 months. We know that it's a different issue. And what do you find out if they haven't been taking their medicines? What do? You find out why. You want to know why. Not taking your medicines. Well, why? Why is it? Because I want to adjust them in a way that's going to be comfortable for you. The taste of Symbicort is very bitter. You don't like that. You don't like the powder. Maybe you need to understand more about it. You think you're going to get pimples and diabetes and obesity from the steroid in your inhaler. This is very common. People think they're going to get really bad side effects from the steroid, so they're afraid to take it. Maybe they're depressed and they don't take any of their medicine. So in order to be an effective doc, if our patients are not taking their medicine, we need to understand why, so we can work with them and adjust things to help either education-wise or side effect-wise. Maybe they can't stand the powder. If I try to do an Advair inhaler, I can't talk for the rest of the day. It's so gritty on my throat. So find out why they don't like to take their medicine. There are lots of choices out there, and let's see if we can switch to something that's more agreeable for you. Maybe the copay is terrible, and that's true for so many patients, that the copay is bad, or it wasn't on your insurance at all. So let's work with the social worker. You can always call me and see if I can figure out what might be, what might work best on their plan. Being able to get the medicine and get it into your lungs properly is crucial in asthma. We use, one of the tests that we use in asthma now is called a fractional excretion of nitric oxide, or the FeNO. Now, FeNO we're going to talk a little bit more about later on, but one of the important uses of FeNO is that it correlates with how well your asthma is doing and how well your inhaled corticosteroid or your oral steroid is taking care of the eosinophilic inflammation in your airways. So if you're not taking your medicine, your FeNO may be sky high because you're not taking your medicine. So one of the things we use it for, and this becomes very useful at times, because sometimes the most sincere individual comes back and says, oh no, my FeNO is really high, I'm not taking anything. And so you got to figure out why. And you don't want to be increasing their medicine if they're not taking what we're already giving them. So this is probably the most important slide in the whole talk, because this is where our patients live and the difficulty of taking medicines. When you're on the floors, I would suggest that you order an albuterol meter-dosed inhaler to the bedside. Put them on albuterol PRN. And then you can say, you've been admitted twice in the last 6 months. Why don't we practice your inhaler technique? Let me see how you do it. And I think you'll find that an incredibly useful intervention, because you'll find out that so many of your patients have really bad inhaler technique. And so right there on the floor, you're able to get a spacer if you need to get a spacer. If you need to switch them to something that's breath actuated rather than a pump, fine, you can do that. But first find out that they can't do it. You have a patient who's 90 years old and you're sending them home on a meter dose inhaler. You better be sure that they can do it, because I'll bet you $50 that they don't know how to do it, or they can't do it. They probably can't even squeeze the pump. So knowing what you're sending your patient home on becomes very, very important. And if they can't do a meter dose inhaler, then they might be able to do a breath actuated. If they can't do a breath actuated, you can order a nebulizer, and they can get their inhaled corticosteroid and their long-acting beta agonist by nebulizer. So there's a spectrum. The spacer is a very good tool, and that's always available on the floor in the clean utility room, or if there are none there, then they can get it from respiratory. Ask the nurse on the floor. So we have lots of treatable traits that are outside of the asthma, and we're going to go through these to tease out what are the things besides just the asthma are part of what we can do to get better besides just medicines. So looking at the triggers, because we have to avoid the triggers in order to the medicines to be most effective. What are the triggers that the person may have? So it could be allergen, it could be irritant, or it could be viral infections. So allergen exposure drives the Th2 response. Remember the left-hand side of the picture where we had the Th2 and non-Th2? Allergen exposure drives the Th2 response. If they're living with a cat and they are allergic to cats, they are not going to get better. Allergen exposure includes, as I said, asking about the air they're breathing, both in the home or in the work environment. One of the things we do is we do some laboratory to see if they're having allergen exposure and how we might modify what they're exposed to, by knowing what they're sensitive to. So in EPIC, you put in an order for an asthma profile. And what comes up in the asthma profile is a total IgE and a RAS test, which is a measurement of IgE according to a variety of common allergens, be it cats, dogs, roaches, dust, mice, several molds, including aspergillus, several kinds of grasses and trees. So this is a very useful laboratory to order, asthma profile. And it tells you how allergic that person is. Is it 100%? No. Does it mean that everything there is urgently, terribly allergic? No, some are milder, some are more severe. But if you're looking at a person who has allergy to a cat and is their best friend, and they're class 5 allergic to the cat in their blood test, it holds a lot of weight. It's not just something you're saying, it's a blood test is showing that you're very allergic to cats. Because once we know what the person is sensitive to, then we're going to recommend mitigation. We're going to recommend avoidance, and we'll talk a little bit more about that. Now, some people are going to be very sensitive to irritants. Cigarette smoke, clearly you shouldn't be smoking if you've got asthma, but nobody should be smoking around you because cigarette smoke is very, very irritating. And unfortunately, some of our patients, the neighbor is smoking and it comes in through the door you'll hear that. And that's very hard on the patient because the cigarette smoke is incredibly irritating. Perfume is irritating. So they get on the bus. We had a patient crying this morning. Someone was wearing perfume on the bus. She starts to cough and the bus driver made her get off the bus because they said they couldn't be sure she didn't have COVID. Irritants are very hard on the asthmatic. Clorox is one of my favorite questions because Clorox is something that most asthmatics really, really react to. And if you're trying to dig out, do you react? Are you, in the idea, are you reactive? Do you react to Clorox is a big one. It's very helpful if you do. Air pollution is irritant. Endotoxin is irritant. And then very often our hospital admissions are driven by viral infections, which we know are big drivers of asthma exacerbations. The asthma patient who's got an allergic, has a viral infection that's triggered their asthma exacerbation is in a different category than the person who has had an allergen exposure and their asthma is due to that. A viral infection is a much more prolonged and inflammatory issue for an asthmatic. They don't clear a viral infection. They don't clear the virus as readily as someone who does not have asthma. And the amount of inflammation and the inflammatory response to the virus results in a much more prolonged need for steroids for hospitalization than one that is from an allergen exposure, where you had an exposure, you got tight, et cetera, and you have a brief exposure and you get better more readily. This is a much more, so don't be surprised if your asthmatic who has rhinovirus, who has RSV or COVID, has a more prolonged course. And this is a picture of one of our patients' New York City apartments. And New York City apartments are unfortunately often in very poor repair. And this is a source of extreme embarrassment to our patients. But we must ask about it because if that's what's keeping them sick, we have to try and help dealing with it. So here's a person who has the lintels over the window are undoubtedly leaking. So the rain comes in above the window, destroys the plaster, gets under the ceiling. And for this patient, the ceiling fell down on her bed. And all of this is mold. So she's living with mold exposure, which no matter, she can take all the Symbicort she wants in the world. If she's living in a place like this, she's never going to get better. So what do we do with this situation? Well, we have a couple of very basic things we do. First is we say we're sorry that they have to live in such degraded housing, of course. but we tell the patient to call 311. 311 is the mayor's hotline. It's not 911, it's 311. And what does that do? You call up and you tell them that your housing situation is what it is, and they will send an investigator to the home, which will then put a violation on the apartment, on the landlord's record. And it also says that this is an actual, it's not just self-reported by the patient, that the inspector went and identified that there was a severe health hazard in the home. It's against the law for landlords to be renting apartments to patients who are living in something that's hazardous to their health. So that must be repaired. So what do you do as the doc? You write a note, a good strong one, saying my patient has severe asthma. They're living in a home where the patient reports to me that they have mold, they have roaches, they have mice, they have whatever kind of contamination might be there. And it is urgent that this is fixed. Make the letter good and strong. Patient will take it to the landlord, and very often it will work. Not always. However, we also have a legal clinic, and you utilize the legal clinic. You can use the legal clinic from Chelsea Ryan, from Thelma Adair, from anywhere. You can send the patients to a legal clinic. And the lawyer will write with Esquire at the end of their name a letter which says this is against the law and you have to fix this. And truth be told, we've published this in the Journal of Asthma, that our patients who went to legal clinic, actually, we never had to go to court because the landlord knows that they're breaking the law, and the patients got better. They came off their prednisone, because if you're living in a house like this, you'll never get better until that gets fixed. So that's part of asthma management, is to understand that. Now, this is a slide I like for patients. Why do I like it for patients? Because I think it's kind of simple and cool. So these are eosinophils, and they're full of granules. And so these are eosinophils in your bloodstream. You live with the mold, or you live with a cat, or you live with whatever it is that you're sensitive to, and that air is in your airways. This is your bronchus. That air that has cat allergy in it is in your airways, and it recruits the eosinophils from your bloodstream to your airways. And so your airways get full of eosinophils, and they have these granules in them that when the cat comes near you, you get an asthma attack. And what's that? It's the eosinophil granules being given off and giving off all these chemicals that make your airways swell, mucus production, muscle spasm. So it's these cells that are here that are driving your asthma. What makes these cells go away is taking an inhaled corticosteroid, getting a biologic if need be, but avoiding the recruiter. And the recruiter is the cat, the mouse, the mold, or whatever it is that you are sensitive to, that you're breathing in, and it's drawing the allergy cells from your bloodstream into your airway. It's a concept that I think is helpful for the patient, because we want to get rid of these cells so when the cat comes by the next time, there are only one cell there rather than 500 to give off all their cytokines. And this is an eosinophilic plug with charcoal-laden crystals. So why do I put this up here? Because what do your patients die of when they have their severe asthma exacerbation? What's in their airway? It's the eosinophilic plug. It's not just a little bit of loose mucus, it's a plug, and it's stuck down there. And plugs in your asthmatic who's taking a long time to get better, when you have them on steroids in the hospital and taking forever to get better, why are they not getting better? It's because they have plugs. Plugs don't just go away with a little bit of treatment. It takes time for them to mobilize and come out. And at autopsy, this is what's in the airways of the mortal patient who has a severe status asthmaticus. Plugs. They don't develop overnight. They develop over a long period of time. But the recruiters are what brought those eosinophils to the airway. So it's important. It's a concept that I think is an important one. So here's a case. So I want one of you to tell me what to do. We have a 40-year-old patient comes to your clinic who has a cat, the love of their life, and they've had 3 courses of prednisone in the last year. You do a RAS test and it's class 5 allergy to cat. What are you going to tell them? Does anybody feel like telling me?
Anyone wants to unmute themselves or post in the chat what you would do or how you would manage this patient? Yeah. If not, we will pick an unwilling volunteer, maybe.
Oh, there you go.
I can talk.
There you go. Darren can call. Okay. So Darren, what would you do?
I think it's Tom, actually.
Okay. What would you do? Sorry.
I think you have to, in a nice way,
Oh, it's
spend
Tom.
some.
Hey, Tom.
Yep. Hey, I think in a nice way, you have to tell them that they have to get rid of the cat eventually. You
Say you're
probably have to
crazy.
spend, you probably have to spend some time counseling and explaining it to them, but I think that's the end goal.
Right. So you have to, and where do cats sleep? Cats sleep on your head. If you haven't had a cat, you don't know that. I've had cats. I had a cat when I was an intern. I could never sleep because a cat slept sleeping on my head. Cats sleep on your head. So if you talk to them about getting rid of the cat, maybe give it to an uncle, a sister, a brother, somebody else. They have to understand, and most people after a couple of steroid admissions do understand that this is really bad for your health, that you can't live with what you're sensitive to because you're going to wind up with obesity, osteoporosis, pimples, diabetes, etc. So education, as you said, Tom, tell them how bad it's going to be for them. But if they can't, let's say they have mice, let's say they have rats, they're not going to get rid of the cat because they have children and they don't want the children living in a house with rats. Welcome to New York. So what do? You do not allow the cat in the bedroom because that's the place where you spend the most of your hours when you're in the home. So you make the cat has to stay outside of the bedroom. You keep the door closed when you're not there so the cat cannot get into the bedroom. Now, of course, many of our people live in studios, so we can't do this. But if you have the luxury of having a door on your bedroom, do not let the cat inside. Then you clean the bedroom like crazy because cats they rub up against everything. They lick and then they rub up against everything. So they put their antigen all over your couch, all over your bedding, all over everything. So you have to clean like crazy to get rid of any cat dander that might be in the bedroom. You can get an air purifier. Medicaid will not cover for an air purifier, but still people will do that to try and keep the air purifier very clean. But if that isn't sufficient, you really have to talk to them about trying to remove the animal from the house. And if you think it's hard with cats, you should try doing this with dogs, with people really are even more attached to than their cats. The allergy to cat is usually very obvious. The allergy to dog is often not quite that obvious. So, and having the blood test to show that your class 5 allergy to cats is a very powerful tool. So, so that's what I would suggest to do with your animals. It's a serious problem. So in terms of recommendation for reducing exposure, remove the animal from the house at a minimum, keep them out of the bedroom, have a HEPA filter if you can, and you can get a vacuum cleaner that has a HEPA filter, but those are very expensive. This covering the air ducts really is more relevant to people who live in private homes, but having the air ducts cleaned periodically in the apartment is important. Now, if you have dust mites, if you live in a dusty apartment and you're sensitive to dust mites, which you'll know from the blood test, encase your mattresses and pillows with allergen impermeable covers. Wash the pillows regularly, which is something odd, but will take help with getting rid of dust mites in the pillow. Wash your bedding weekly in warm water. Cold water does not get rid of dust mites. And reduce the humidity in your bedroom if you can to a low level. Remove the carpets from the bedroom. And again, we emphasize bedroom because you spend the most hours in your bedroom. And if you have upholstered furniture, if possible, switch to leather, vinyl, or wood because you could wipe that off. Upholstered furniture holds dust, so the dust mites get in there and you take a nap on your couch and you may wind up with an asthma exacerbation. Cockroaches, baits or traps, water, get rid of water, leaks. Cockroaches love water. So dry the sink, dry the place where the dishes drip when they're drying, and obviously put all food away and keep the home as clean as you can. But get exterminators and the roach traps to help with the roaches. If you have mold, you have to get rid of the dampness. So leaks have to be fixed. Moldy surfaces should be cleaned with dilute bleach. Don't let the place be too humid. So some of the apartments in the bathrooms in New York City don't have a vent. Or if they do have a vent, it's not been fixed in a while, so it doesn't work. So every time you take a shower, the humidity builds up in the bathroom. So you want to try to either open the window if you have a window or get the vent fixed. But getting the humidity out of the bathroom really helps with not having mold in the bathroom. And then rodents, rodents, you want to close all holes, identify where the rodents are coming from. So you put steel wool in the hole and then you plaster over the steel wool. And it should be a very high grade steel wool. All food should be kept in sealed containers. And unfortunately, if you live next door to the garbage disposal, it's often a problem. The building must bring in the exterminator. And so this is also an issue. So this is what we talk to our patients about. But what about when we examine our patients? What do we do? So we look at their weight. In asthma clinic, 50% of patients are obese and 20% of patients are morbidly obese. And leptin is pro-inflammatory, the steroid, the hormone that's given off by fat. So it's going to make it harder for your asthma to get better. And you're always going to be short of breath because you're carrying a load. We want to look at the Melon-Potty because there's a big overlap between OSA and sleep apnea. Ask them about hypersomnolence or observe that they're hypersomnolent. We want to look for nasal polyps, and I have a picture in the next slide what they look like. They're glistening, and they are allergic phenomenon associated with adult onset asthma and recurrent sinusitis. And so we want to definitely make note of that because they respond to dupilumab, one of the biologics. We want to identify what kind of wheeze they have. Asthma's wheeze is an orchestra as opposed to a flute. It's a whole bunch of different instruments as opposed to a single sound. So the sounds, the wheeze is distributed, it has many tones to it, whereas if you have a single sound, especially if it's a single sound in the similar pattern, that suggests that there's a central airway obstruction, which might be something like a bronchial narrowing, or it could be something like a foreign body or vocal cord dysfunction, which we definitely see. So if you have, when you're listening, see is the sound distributed, or is it localized more over the central airway, especially over the vocal cord region, and the sound is the same with every breath. If they're very severe, the chest may be quiet. You want to differentiate on your exam. Do they have bronchi? Do they have squeaks? Do they have stridor? Or is it just that polyphonic wheeze? A bronchus is much more coarse, suggesting that there's mucus in the airway or central airway obstruction. If they have squeaks, it's a bronchiolitis. So it's this kind of a very distant, squeaky sound. That's a bronchiolitis. And do they have stridor? Obviously, we're concerned with upper airway. And then are they using their accessory muscles as a signal that they have severe disease? This is the nasal polyps. So going on to what testing we do spirometry. Obviously, we're going to look for airway obstruction. We're going to look for bronchodilator responsiveness. which would be 200 cc's increase in FEV1 or FVC actually, but in asthma we're looking for the FEV1, and over 200 cc's increased bronchodilator and 12%. On the flow volume loop, we want to look for upper airway obstruction, and I'm going to show you that on the next slide. Why do we do periodic spirometry? Because asthma is associated with a more rapid decline in FEV1 over the years than for patients without asthma, 22 cc's per year loss rather than 38. So what do we look at in the flow volume loop when we're looking? If you're obstructed, you're going to have a decrease in the flow, a concave flow volume loop. But I put this one up here to be an example of vocal cord dysfunction because it's showing an upper airway obstruction. So here is in and here is out on your flow volume loop. This is volume and this is flow, right? So this is in, so upper airway obstruction or stridorous breathing are going to be evident on in, right? And in the patient who has vocal cord dysfunction, they actually close their vocal cords on inspiration and breathe through this tiny little chink. So here's vocal cords that are normal and open, but for vocal cord dysfunction, they breathe through closed cords, which doesn't let a lot of air in. So they're breathing in, and so this is the upper airway obstruction of vocal cord dysfunction, or if you had a carcinoma of your larynx, any upper airway obstruction. But upper airway obstruction is something you want to be aware of because we do see that in our very, very noisy asthmatics who are in the ER, often quite frantic, and they've been intubated 11 times. And you will see these patients, very, very noisy breathing. They can become hypercarbic even because they are breathing through closed vocal cords. And once you intubate them, the wheezing goes away. And those patients, you want to make note of that. That's so important that they're terrible, terrible, terrible. You intubate them and the wheezing goes away. That means it's an upper airway obstruction because those patients really need speech therapy to relax their vocal cords. It's a big deal for them and it can be life-changing if you can get them good speech therapy to look at their upper airway. So when you order your, oh, we have 10 minutes left. I just got a message. Okay, so upper airway and the PFT. When you order your PFT, I should have made clear. On your blood tests, you order two tests. You order a CBC with diff and you order a asthma profile, which will give you the IgE and the RAST. When you order your PFT, you order nitric oxide. It's a separate order from the PFT. It's not under the order for PFT. And nitric oxide is FeNO, which is exhaled nitric oxide. It corresponds to eosinophilic inflammation in the airway that's uncontrolled. So it's very simple for the patient to do. They have no trouble doing it. In well-controlled asthma, it's under 20. If it's under 20, it's either very well-controlled asthma or it's not asthma. It's high if you have uncontrolled eosinophilic inflammation, which might be due to the severity of their disease, or it might be due to the fact that they're not taking their medicines. So if it's over 50, uncontrolled eosinophilic inflammation, between 20 and 50, it's indeterminate. And if it's under 20, it's less likely in eosinophilic inflammation, or it's something that's not steroid responsive. PFT, you're going to order your full study and a separate order for nitric oxide. Can spirometry be normal in asthmatic? Does anybody want to take a quick answer at that?
I'd say yeah, it could probably be normal in asthmatic because, as you mentioned earlier, you could have like exercise-induced asthma, and if you're not doing spirometry when a trigger is there,
right?
Then,
Exactly. So a normal PFT does not rule out asthma. If we were going to do something to rule out asthma, then we're going to say that that this is not asthma. We'd be looking at a methacholine challenge. You can definitely have a normal asthma and be at a normal PFT and have asthma. Can you have a false negative bronchodilator response? Also, yeah, if they didn't give enough of the albuterol at the time, if they used a bronchodilator before they took the test, if they only get their symptoms in the spring and they're doing the test in the winter, it may not be show the bronchodilator responsiveness. Or if they just have a little bit of airflow obstruction at the time of the testing, it may not show. What about peak flows? They're useful. They're useful. They're very helpful. You can have the patient self-monitor themselves when they use the peak flow. It's very variable. It has to be done with great effort. It's really high effort, but it can tell the patient if they're having bronchospasm versus panic is one of the things I really like it for, and can be very helpful in supporting the diagnosis. A blood eosinophil level. We can't do a sputum eosinophil level, a very expensive and very it's complicated test to do, but we can do a blood eosinophil level. And this is also very useful along with the RAS testing. Now, when you look at your eosinophilia, it won't come up as eosinophilia according to the hematologist, but for the asthmatic, we're looking at the absolute number of eosinophils, and eosinophils as low as 150 are considered eosinophilic for the asthmatic. Most of our bad asthmatics, where we're thinking about giving them a biologic, we're looking at an eosinophil count of 300. But we're looking at the absolute eosinophil count, not the percentage. And why do we especially look for this? Because the eosinophil count is very much under the control of certain cytokines. IL-5 is one of them, especially. So if somebody has very high eosinophil count, we're going to be giving them medications that interfere with their IL-5. IL-4 is also relevant for eosinophil count. It's more for the recruitment than the production and the development of the eosinophils. So drugs that are against IL-4 are also helpful with the patient. But for the really eosinophilic patient, we're looking at drugs that are inhibit IL-5. So we have another biomarker. We have IgE. So that's for your atopic person, and that will go along with a person who we're thinking about giving them Xolair or omalizumab, which is an anti-IgE. Now, much of the patients will have will have IgE, and they'll have some eosinophilia. So you want to be looking at how much is the childhood onset high IgE anaphylaxis urticaria kind of person who's not controlled on their basic medicines. I'm going to be thinking about giving them Xolair. We do bronchoprovocation testing is another test where we give them something that's irritating like methacholine, give them repeated doses of methacholine and see if they respond to it. If you do respond, you may have asthma, but you may also be normal. But if you don't respond, you don't have asthma because you're really insensitive to an irritant. And that's how it's done. The asthmatic, the normal can take lots of methacholine before they drop their FEV1, but the asthmatic is sensitive, so they're going to drop their FEV1 at a low level of methacholine. So again, the concept, atopic asthma is the young onset, bronchodilator responsive, very allergic, IgE, atopic. Not all asthmatics fit this picture. We're going to move across that picture that we had up a minute ago and look at, as they get older, we're going to be looking at more about the Th2 eosinophilic asthma, where we're looking at the eosinophil count, we're looking at the FeNO, also the total IgE, but we're going to be thinking that this is not so much atopic, but adult onset asthma. And here we go, atopic, eosinophilic, more the adult onset, more severe, difficult to control with your inhaled corticosteroid long-acting beta agonists, may be responsive to your anti-IL-5 or your anti-IL-4/13 biologics. This one is more, you're thinking of your Xolair. These ones you're thinking of your Mepo or your Benra or your Dupi. And then we have the ones that are not eosinophilic, which are not going to respond to those. This is just repeating what we said. This is again repeating. 300 or more eosinophils are where we're really talking about when we're thinking about someone who may respond to biologics. Exercise-induced is not just getting bronchospasm when you climb the stairs. Exercise occurs after the first 6 to 8 minutes of exercise, where you get a bronchoconstriction that may last up to 60 minutes. This is a much more complicated thing, and you get prostaglandin release, and after that you get better. So simple shortness of breath from deconditioning resolves quickly. This is something that goes on and on and on. And how do you manage it? You give them good overall asthma control, and you give them their bronchodilator before exercising, and that's very helpful. Nocturnal asthma may be hormonal, they may have GERD, they may have sleep apnea. Separate out the asthma from the COPD. Asthma is reactive and reversible. COPD is there every day of their lives. They can never climb the stairs. They always need their albuterol. They always have a low peak flow as the person with asthma who is more reactive and has a more reversible component. But lots of asthmatics smoked. And so you're going to have those patients who have both. And this is a very important concept for both you as the provider and for the patient. If you have asthma, we're looking to try and get you so you don't need your bronchodilators. But if you have COPD, you're always going to be short of breath. You're never going to have that reversibility. So it's a concept that's difficult for us to accept, that the person's always going to be short of breath, but we shouldn't be giving them more and more steroids and things like that as though it was an inflammatory thing when these people ran out of lung. And then for the patient who has both, you have to modify because you have to put the judgment used for both diseases. Obesity, pro-inflammatory, you're always short of breath. So we want our asthmatics to talk to them about weight loss, talk to them about healthy diet and exercise, because it's so important that they lose weight. But we can't expect to get them not short of breath if on top of the asthma they have obesity, because the obesity is contributing to the shortness of breath. Same thing with sleep apnea. They've got fatigue. 50% of patients who have severe asthma also have sleep apnea. 25 to 50 of moderate have sleep apnea. It's very common in this population because they have nasal obstruction, they have irritated upper airways. So there's a feedback back and forth between the inflammation of asthma and the impaired, relaxed, decreased cross-section of the upper airway in the sleep apnea patients. So there's a tremendous amount of overlap. And there's the driving feature of leptin, which makes the airway more inflamed. Then we have severe coexisting illnesses in asthma. We have ABPA, which is allergic bronchopulmonary aspergillosis. And we have Churg-Strauss, which is also called Eosinophilic Granulomatosis and polyangiitis. So your ABPA person has plugs and IgE that's crazy high and allergy to aspergillus. Your Churg-Strauss patient or your eosinophilic granulomatosis patient started off with sinus disease, started off with a lot of eosinophils, and over the years it got worse. So they got eosinophilic infiltration of their lung and eventually got eosinophilic infiltration of their blood vessels. So they wind up with cardiac damage and peripheral nerve damage. And here's your typical ABPA kind of destruction of the central airway due to the aspergillus, and this is aspergillus plugs in the airway. Important to diagnose, yeah, because it destroys the lung. So concept, severely poorly controlled asthma versus severe asthma, these are two different things. Most asthma is just poorly controlled. So it's the cat that's sleeping on their head and the poor technique and the difficulty of the housing and all these other things that contribute to most asthma. But some people have truly severe asthma, but that's only 10 to 15% of asthma. We use an asthma control test. We want our patients to have less than 2 weeks, 2 rescue pumps in the week and not wake up with nightly symptoms. But here's the symptom that I find most important, and I want you to ask all of your patients. How many times in the last year did you wind up in the ER? How many times in the last year did you need prednisone? Are we out of time?
Yeah.
We're over. Okay, just one more thought, which is now with the GINA guidelines. The GINA guidelines have changed, right? Well, now with the GINA guidelines, they finally realized that patients do not take their controller medicine every day. They take their Symbicort when they're sick, and it works. So the GINA guidelines took about 5 years to figure this out, and they figured it out, and it's good, because that's what when a person needs their albuterol, they also need an anti-inflammatory. That's why they need their albuterol. So even people with mild asthma can wind up with a severe asthma attack. So the GINA guideline says, if your patient needs rescue, and it's on their insurance plan, because it's not on all insurance plans, you give them the low-dose inhaled corticosteroid and the salmeterol. It has to be formoterol. Can't believe I said that. Formoterol. It has to be formoterol because that's the only one that has both rapid onset and long-term effect. If you use the other, you can't do it with Advair, you can't do it with the other inhalers. It has to be with Symbicort because it has the inhaled corticosteroid and the formoterol. And that's the one that's going to give you rapid relief as well as long-term relief. If your patient's insurance does not cover that, what they are recommending as a second choice is to take an inhaled corticosteroid every time you take your short-acting beta agonist. So that's the big change here, is that we don't use short-acting beta agonists alone. We use it with an inhaled corticosteroid at that time, or we give them a inhaled corticosteroid plus formoterol as rescue. So I'll stop there.